I have the pleasure of introducing Dr. Jacqueline Becker, who is a clinical neuropsychologist and health services researcher at the Icahn School of Medicine at Mount Sinai's Division of General Internal Medicine. Currently, she is leading the effort to assess post-COVID-19 cognitive functioning in patients treated through the Mount Sinai Health System, and she is a co-investigator of a randomized controlled trial of cognitive rehabilitation for long COVID patients. She is also chair of the International Neuropsychological Society's NeuroCOVID Long-Term Outcomes Task Force Committee. Dr. Becker will present on an overview of the impacts of long COVID on behavioral health, cognitive and psychiatric symptoms, and potential mechanisms. Dr. Becker, you have the floor.
Great. Thank you all so much for having me here today. So I'm just going to present sort of an update on the literature and what we know now about long COVID and specifically the cognitive and behavioral health effects of long COVID. So I start my talk in a little bit of an unconventional way here. I'd like you all to just take a look at this image, and I'm going to use a technique that we psychologists call guided imagery. So feel free to close your eyes or you can keep them open if you prefer. But the point is really to imagine yourself here. So I want you to imagine that you are driving your car down a road that is very familiar to you. Then suddenly you get a flat tire. And while normally you would pull over and try to fix it, it's storming outside and lightning is striking everywhere. So instead you try to keep going. Your car is still working, but steering and accelerating are a bit more effortful. Braking becomes problematic, so you have to drive very slowly. Even when you try to speed up to switch lanes, the car moves sluggishly. It just lacks its usual responsiveness. Each turn of the wheel requires extra effort, and progress feels frustratingly slow. You start to wonder whether you should call someone for help, but everyone you know is also in a storm, and many of them also have flat tires. So you just keep trying on your own to move through the storm as best as you can so you can just get home. You feel like you must be close to home. This must get better soon. You start seeing other people pulling into their homes, but yours is so far away and you begin to wonder if you'll ever get there. This is what living with the cognitive and mental health effects of long COVID feels like in the middle of a global pandemic. Patients say they feel like their usual functioning has been disrupted and everything is a blur, confusing, difficult. Tasks that were once effortless, like remembering details, concentrating at work, or even just expressing thoughts clearly, have now become arduous and draining. Now imagine that you feel like this every day. Some day was worse than others, but now the storm is gone and people are trying to forget it even happened. But somehow your tire is still flat. And when you go to the mechanic, they look at your tire and they tell you it's normal and you should just get back on the road and keep driving because there's nothing technically wrong with your car. So this has been the experience for millions of Americans for over 4 years now. And while many people with long COVID have improved, others are still driving with a flat, waiting to get back to themselves. So I wanted to give you all this introduction just to give you a sense and to really sort of put ourselves in the shoes of people living with long COVID to understand sort of how arduous and draining and difficult it has been for them, not just during the pandemic, but even more so now that the pandemic is over and everyone tends to have something called COVID fatigue, right? Where no one wants to hear about COVID anymore, or many people don't. Some people are still interested, but mostly if you recover from COVID, you're feeling okay and you just want to move on from the pandemic. So I just really wanted to give you all a sense of what that might feel like. With respect to epidemiology, so how often does long COVID happen? The most recent update in the prevalence suggests that it occurs in about 10 to 30% of COVID survivors. And this translates to somewhere around 17 to 23 million people in the US alone. Globally, it tends to be a lot higher than that. I think the last estimate was about 52 million. But approximately 79% of those report activity limitations. So whether it's work or school functioning, because it does happen in children as well, or people just not being able to go back full time and having to do part time. It's been a really big challenge for a lot of adults and children. So it's presumed most likely in middle-aged adults, actually, and studies have found that it can occur in people who were previously healthy with no pre-existing conditions. It tends to be regardless of COVID severity, though it may be more pronounced in those with severe COVID, and we'll go into that a little bit in a minute. But individuals presumed infected with any and all variants may still be susceptible. There is some data that vaccination may decrease risk of long COVID, and few studies have found that the original variant conferred greater risk for long COVID than the Delta or Omicron variants, but we'll talk about that in a little bit as well. So just to sort of clear the air here about terminology, I'm sure you've all heard of a lot of different terms, right? So long COVID, post-COVID conditions, post-acute sequela of SARS-CoV-2, long-haul COVID, right? The list sort of goes on and on. But just to sort of clarify where all these terms come from and what they mean. So long COVID was a term initially coined by patients who called themselves long haulers. And this happened back in April 2020. And this early recognition by the patient community and their efforts to organize it and name the condition is really what alerted the world to study it. And then eventually this CDC picked up post-COVID condition and was designated as the official term for the CDC and for the World Health Organization. And it covers sort of a wide range of health consequences, all due to COVID, including secondary and tertiary effects. And then PASC later emerged as a somewhat parallel term through the NIH, and it refers to sort of the direct and indirect consequences of SARS-CoV-2 on human health. But for the purpose of this presentation, and all presentations I give for that matter, I opt to use the term long COVID because it was the first and most inclusive term and also recognizes the patient voice when describing the long-term health effects of SARS-CoV-2. In general, our understanding of what long COVID is still rather limited, and there are still many differences in how it's being classified. Just so that you're aware, the National Academies of Science, Engineering, and Medicine is about to release a report. They put together a committee that has been working on this for about, I think, 2 years now to sort of better define long COVID or PASC or post-COVID condition, and to sort of come up with appropriate terminology for that. So that should actually be, I think it's June 11th that the government is planning on releasing that report. So be on the lookout for that. But as of 2022, the U.S. Department of Health and Human Services, in collaboration with other departments in the government and alongside patient groups, formulated this definition. And this has been our working definition since 2022. And it broadly defines long COVID as signs and symptoms and conditions that develop after initial COVID-19 and are present for at least 4 weeks or more after the initial phase, can be multisystemic, present with relapse remitting pattern, could progress or worsen over time, could also improve. Was also clarified that long COVID is not one condition, but rather represents many potentially overlapping conditions, likely with different biological causes and different sets of risk factors and outcomes as well. So importantly, though, while the CDC recognizes the definition as being 4 weeks or more after the initial phase of infection, the World Health Organization actually considers it 3 months after initial SARS-CoV-2 infection, which is a lot more of a stringent cutoff and lasting at least 2 months. And so studies vary greatly in terms of which definition they use to define long COVID. It's a highly heterogeneous condition, so there are about over 200 different symptoms that have been reported across multiple organ systems. It can impact people at all levels of functioning and have significant physical, social, and psychological consequences. So among the most common, actually, and most debilitating is something called brain fog, which has been used interchangeably with cognitive impairment. But the term brain fog, while it's become sort of this catch-all for the wide range of cognitive effects of long COVID, it's important, I think, to differentiate because brain fog is not itself a diagnosis, but rather a self-reported symptom, whereas cognitive impairment represents objectively measured deficits on neuropsychological tests. So patients often report forgetfulness, confusion, difficulty concentrating, difficulty finding words. That memory problem tends to be a predominant concern and complaint for most patients who report brain fog. Interestingly, though, we don't always capture this beyond a clinical threshold for impairment on neuropsychological tests. And it doesn't mean it's not real, it's absolutely real, but it may have a different etiology or simply be above a level of severity that we typically classify as impaired based on neuropsychological tests. Cognitive impairment, on the other hand, is defined as impairment on these neuropsychological measures that I mentioned, usually 1 to 1.5 standard deviations below the normative mean. And in long COVID, the cognitive profile is typically characterized by attention, processing speed, and something called executive functioning, which is essentially akin to like the CEO of the brain, which helps us think abstractly and helps us reason and problem solve and multitask and initiate and motivate. And so deficits, even in executive functioning alone, can really impact all of those other domains and really make you feel like, for example, there may be memory problems in the absence of actual memory problems on testing. And just as an aside, and I'll get into this a little bit more toward the end, but this has become a really big challenge for people applying for Social Security disability in the United States, because the Social Security disability requires objective evidence of impairment. And sometimes people with brain fog just don't have that. And so it's been very challenging. And so myself and others in a committee have been working with the national academies to sort of advise the Social Security Administration on long COVID and sort of just clarify the research in order to improve this. So this has also led to a big degree of stigma actually associated with long COVID, where patients are often told, well, you're normal on cognitive testing, so it's probably just anxiety or it's probably just depression. And so there's been a big stigma for a lot of these reasons. Another important nuance to really understand the research on this topic is that the differences in the ways in which cognition is assessed across studies differs drastically. So the prevalence estimates in meta-analyses have ranged from 8 to 80%. This is largely due to differences in measurement, where most studies will use dementia screeners, for example, like the Montreal Cognitive Assessment or the Mini Mental Status Exam, which really are insensitive to detect the level of impairment that we see in long COVID. Several studies have also used remote or web-based surveys that have not been validated. An example is a recent New England Journal of Medicine study that you may or may not have seen. It was quoted in the New York Times about how there's a 3, 6, or 9 point drop in IQ depending on COVID severity. And that study really was based on a large survey that was administered at random to whoever decided to respond to the link that they were sent, using a measure that, again, was not validated. And so taking some of those findings with a grain of salt, I think, is important. And obviously, a lot of people don't know to do that. So just to enlighten you on some of the issues with the literature at this point, other studies also will use self-reported brain fog. So they'll say cognition improved according to 200 patients that self-reported symptoms. Well, unfortunately, self-report doesn't always align with the objective measures that I was referring to earlier. And so again, those findings tend to make the literature a little bit murky. Some studies will also lump patients regardless of COVID severity, and this is problematic, probably because there are different causes to cognitive impairment depending on COVID severity. And then finally, there's sort of an inherent selection bias in a lot of studies, and that's a big problem. What I mean by this is that there's these sort of large-scale epidemiologic studies that capture the general COVID population and see who from there has long COVID. And then there are these often smaller studies from outpatient clinics that will capture patients seeking care for long COVID specifically, and then see who among those has cognitive impairment. So again, you're likely going to get a very divergent cohort in terms of the prevalence of mental health and cognitive sequela. So what do we know about these issues over 4 years now since the onset of the pandemic? I'm going to first simplify and then I'll expand. So first, we know that there is unequivocal scientific evidence to suggest that COVID is associated with cognitive impairment in a subset of the population, and that this is common and largely functionally impairing in those impacted. And two, that the mental health effects of COVID-19 are not just a product of pandemic-related stressors, but are likely reflective of changes in brain health and physical health, not to mention potential damage to the central nervous system in a large proportion of the long COVID population. So why is that? What are the mechanisms? Well, we're still working with a variety of hypotheses regarding the pathophysiology of long COVID. And part of the reason that we still have so many different hypotheses is because it's probably different for a lot of the individuals with long COVID. It's likely that there's not only one cause, and it's likely that it varies greatly depending on individual factors and depending on COVID severity. But generally speaking, the consensus at this point, and again in 2024, is that among the most common and likely mechanisms of long COVID is viral persistence, systemic inflammation, reactivation of other viruses like Epstein-Barr virus, for example, gut dysbiosis, vascular dysfunction, and autoimmunity, or sort of like an aberrant immune response. So those are some of the working hypotheses at the moment. There are definitely others in the works, but these are essentially the ones that have substantial evidence behind them as of 2024. So I've gotten this question very frequently. What about the psychological and psychosocial aspects of the pandemic? Can brain fog be caused by these factors? And the answer is a bit complicated. First, we know that cognitive impairment is a cardinal symptom of depression, and that depression can contribute to impaired cognitive performance, as can anxiety. We also know that cognitive deficits can precipitate or exacerbate mental health problems. However, in long COVID, no causal relationship has been established. Studies have actually shown that cognitive impairment can occur regardless of mental health symptoms in all acute severity groups. And in fact, some studies have suggested that even after mood issues remit, that cognitive symptoms persist. So we definitely can't attribute it all to mood issues. All that said, the stress of the pandemic absolutely can take a toll. And we also know how much social determinants of health can impact cognition and mental health. So these can't be discounted as playing a role. And then the story with fatigue is similar. A causal relationship has not been established, and many studies controlling for the effects of fatigue have still found cognitive impairment to persist. But if you've ever gotten a poor night's sleep, you can probably attest to how much fatigue can impact your mood and sort of your ability to think clearly. So again, it likely plays a large role, but the impairments we see are in excess of what would be expected when considering fatigue alone. The evidence from brain imaging is pretty compelling. There have been a lot of studies that have shown an association between cognitive impairment and changes in gray matter, so the structural parts of the brain. The figure below sort of shows that the regions that have been implicated, and I won't really go into this, but most prominently using different imaging modalities. The most well-known study to date is the longitudinal UK Biobank study, and they actually were able to compare brain scans of patients before the COVID pandemic to the same individuals post-COVID, and they found significant changes. And largely, these were patients with mild COVID. FDG PET and EEG studies have also found signals for frontal areas of the brain, which mediate the executive functions that I was talking about earlier. And so this is consistent with what we see in terms of a cognitive profile. Does COVID severity matter is another question that I get frequently. The short answer is yes. Hospitalized patients are likely to have more severe deficits and mental health problems across the board. But this was also the case in pre-pandemic hospitalized and ICU treated cohorts. So it's likely that mechanisms for worse outcomes post-hospitalization have more to do with hospital and treatment related factors that are then compounded with the effects of SARS-CoV-2 on the brain. So using data from the Mount Sinai post-COVID registry, my colleagues and I published on the frequency of cognitive impairment, and this was in a cohort of 740 post-COVID patients. And we found that 8 months post-COVID diagnosis, about 24% of our relatively young cohort, so the mean age was 49 here, had cognitive impairment in at least one cognitive domain on validated neuropsychological measures. And as you can see, it pretty clearly indicates that those treated in inpatient settings had the greatest frequency of impairment in comparison to those treated in the ED or in outpatient settings. And again, the average time since COVID diagnosis for this cohort was about 7.5, a little over than that, 7.5 months. And we adjusted for race, ethnicity, smoking history, BMI, fatigue, and comorbidities, including depression. Another question I get, and I mentioned earlier, is do variants matter? Some studies have found that the risk profiles for cognitive and psychiatric diagnoses were greater during the Delta variant period, Whereas other studies have found that the Delta variant period was associated with better cognitive performance and that it was worse during the initial variant periods. So as of yet, we don't quite have evidence that variants matter. However, this also could be skewed to some degree and related to geography in some way. And what I mean by that is that certain variants reach different parts of the world at different times. And the only way that we can know who was infected by which variant is by using the date of infection as a proxy for which was the most common variant around at that time. And so there's going to be a lot of bias in that research. And then the other question is, do vaccines matter? So one consistent finding is that fully vaccinated individuals have been at lower risk of mental health and cognitive outcomes following breakthrough infections. However, they are also at lower risk for having severe COVID, and the data is often confounded by the variants. And so it's unclear whether that plays a role in the data or not. But overall, several studies have suggested that vaccination may help prevent long COVID, whether it's because of COVID severity or because of the periods vaccinations became available, we don't know. But in general, it seems to play a role in the prevention of long COVID. And I'd be remiss if I didn't briefly touch on the health inequities in long COVID. We know that the pandemic widened health disparity gaps, causing greater health inequities in priority populations, which contributed to greater morbidity and mortality from acute COVID in folks who already had higher rates of viral exposure, worse access to care, lower rates of vaccination, and higher baseline comorbidities. So it's not entirely surprising that Black and Hispanic Americans are actually more likely than white Americans to have symptoms of long COVID. What is interesting, however, is that the symptom profile is thought to be somewhat different. Black and Hispanic Americans had lower odds of brain fog, sleep problems, and fatigue, but had greater odds of blood clots, chest or joint pain, diabetes, headaches, and shortness of breath in comparison to white Americans. So this is interesting. There are a lot of reasons this may be. The study was based on self-report, so it's very possible that certain populations may not want to report certain symptoms that are more stigmatized, like brain fog, for example. But generally, this was the finding, and we need more research to see if it's consistent. And so how much is functioning impacted is another question I get. As I mentioned before, the impact of these symptoms to patient functioning does vary greatly, but a recent study reported that 50% of people with long COVID have experienced a change to their employment status. And again, that was 79% that had some sort of functional limitation. Fortunately, long COVID is considered a disability under the ADA now, which can help patients get reasonable accommodations for school or work. But in order to qualify for Social Security disability, there are much more stringent criteria. So for adults, disability is defined as the inability to engage in substantial gainful activity by reason of a medically determinable physical or mental impairment or combination of impairments, which is expected to last for a continuous period of not less than 12 months or result in death. And so to meet this definition, you must have a severe impairment that makes you unable to do your past relevant work or any other work, any other substantial gainful work that exists in the national economy. So if you were a surgeon before and you can no longer perform surgeries, but you are able to still work a cash register, for example, you would not qualify for disability. One study in China actually found that 12% of patients with long COVID did not return to work even after 12 months. But because of the scale of the pandemic and the amount of people with long COVID, even 1% disability at 1 year can have a tremendous economic impact. And so for those of you who have ever or completed a Social Security disability application or help others do so, when SSA evaluates a claim, there needs to be sufficient evidence of one impairment. So you have to establish objective impairment. Two, the degree of functional limitation needs to be sort of inferred. And then three, and this is a really tricky one to answer, but you have to extrapolate from parallel illnesses for this portion, but you would need to project the probable duration of the impairment. And so it's difficult because we don't know how long COVID lasts for. And some studies have suggested that it persists, and some studies suggest that people get better. When looking at self-reported symptoms of long COVID more broadly, not just the cognitive and mental health effects, but we see that at 24 months, 71% of respondents still reported one or more long COVID symptoms, with fatigue being the most common symptom, followed by amnesia or memory loss, about 30% or so, concentration difficulties, insomnia, and depression. Again, those are some of the most common symptoms of long COVID. But again, these are self-reported symptoms, and so it's likely going to be distinct from those captured on objective data. So are there available treatments? That's another million-dollar question. With a subset of the population improving, but others remaining with impairment, this is a really important question. So first off-label medications and supplements have been prescribed in many clinics around the world, and many of these are now being studied in clinical trials. One popular combination recently from researchers at Yale has been mixing Intuniv with NAC, which is a supplement. It's a combined therapy that was actually approved by the FDA, I think, in 2009 to treat ADHD, and has been found to be successful in relieving brain fog and cognitive impairment in a small cohort of patients. But clinical trials are, of course, still needed in that regard. So low-dose naltrexone has also been commonly prescribed in long COVID, and stimulants as well. But again, clinical trials are still needed. Non-medication treatments are things like cog rehab, transcranial brain stimulation, cognitive behavioral therapy, and acceptance and commitment therapy, which I know these are sort of more behavioral interventions, but they tend to be very effective for people with these sort of mind-body disorders. Even cancer patients tend to benefit from them in the absence of any kind of mental health issues. And one of these clinical trials that is doing cog rehab and transcranial brain stimulation is actually Recover Neuro, which is part of the NIH's initiative to fund long COVID research. And so I'm actually one of the PIs of Recover Neuro. So if anyone has any questions about that specifically, feel free to email me. But in general, I think despite everything we discussed here today, I think it's safe to say that there's still many unanswered questions and challenges that demand attention from federal agencies and organizations. Firstly, I think it's imperative that we prioritize funding for long COVID research. The support enables a deeper understanding of the mechanisms underlying cognitive and mental health effects and can lead to more effective treatments. Enhance communication, not just broadly between the public and healthcare providers, but I think disseminating reliable data and insights is hugely important, and fostering advocacy and empowering individuals to seek care is really important. Fostering collaboration across sectors, and I just mean healthcare research, policy advocacy. It's just helpful to have sort of multi-prong approach to tackle the multifaceted nature of long COVID. And in general, I hope that my talk has been useful and that everyone can sort of commit to helping this cause however we can and driving some meaningful change for patients with long COVID. So thank you so much. And with that, I'll open to any questions.